Good evening, all. Welcome back to my FEFenses and the European Fertility Society. We've been pretty busy at ESHRE, and I know that Alan was there as well. We didn't have a chance to meet up, but I'm glad that we are here once again with you. Dr. Alan Thornhill is with us. Hi, Alan. Great to see you.
Hi.
It's going to be an interesting session. I already said that this is definitely an interesting topic as well. How are you feeling? Welcome to my FEFenses.
Great. Yeah. I'm really well, thank you. I was at the big European meeting. Unfortunately, the last day was ruined by a bomb scare, as I was just telling you. But it didn't interfere too much with with all the excitement and other things going on.
That's what matters, of course. So thank you so much for joining us once again. As I mentioned, we will talk about PGT-A, and of course, Dr. Alan Thornhill is the best person to actually give you some tips on that. And we will start with his presentation. But as always, I know that you are here for the questions. So remember, you can put those in the chat, and Alan will definitely take care of those for you right after the presentation. Remember, it's all being recorded, so don't hesitate. This is an interesting topic. So PGT-A, genetic testing, does it make sense? I think it's a thought-provoking question that many of you have been wondering about. So I'm happy that we are going to discuss it. And now I think we can go ahead with our presentation, as I've mentioned, and then we will take care of your questions. You can type the questions during the presentation or afterwards. It's up to you, of course. So let's start. Okay, let me just check if all is okay. Let's start sharing your screen, Alan. Okay.
Okay. Yeah, and you tell me whether it's working or not.
Of course, definitely.
Okay.
Yeah, it's working. And let's do the full screen and it should be fine. Yeah, perfect. I can see it perfectly. So
okay, perfect. Okay, great. Thanks very much, Caroline, for that introduction. I don't know if I'm the best person to speak about it, but hopefully kind of a good person to speak about it, because this is like my special area of interest. So I'm interested in a lot of things around IVF, but this is something I've spent a lot of time on during my career. Now, the good side of that is I've got a good breadth of knowledge, and you're probably not going to surprise me with your questions. But also the bad side is sometimes I can go on too long, so I've got to be careful not to get into too much detail that might not be useful for everybody, but kind of cover everything, so at least you know where to sort of hang a question on. So we've titled this PGT-A, Does It Make Sense? That's kind of a vague title, but as you'll see, we'll be asking a lot of questions as we go through. So the things we're going to cover tonight are what is PGT-A. Now, I'm pretty sure that anybody coming to this particular webinar probably has at least some idea of what it is, but we'll all get on the same page to start with, because our field and medicine and science in general is full of acronyms, full of these letters that you're supposed to understand what they mean, and you can get a lot of confusion by listening to something and going, oh, that's not what I thought it was. So we'll explain what that is right at the top of the webinar. Very basically, how does it work? So we won't go into huge amounts of detail because we could go down a bit of a rabbit hole with that. This is all about the practical aspects and what you should care about and what you should be concerned about. And then I've put possible benefits and limitations. Normally we say benefits, but I want to make it clear that there, in some cases and for some patients, there are only possible benefits, but there are some definite limitations. So when I talk about limitations there, it doesn't mean it's not worth doing. It just means those limitations definitely exist, and you should be very clear about that. So then we'll cover who should consider PGT-A and why. Now, I'm very aware that in some clinics in some parts of the world, it's not even a question of who should consider it. Everybody gets offered it, and pretty much everybody gets it. So this would be a bit of a pointless webinar if we were in that world, when we were saying, well, who should have it, when everyone's going to get it anyway. But I think we're still in a world where it's worth asking that question and thinking whether it's the right thing for you. Is it worth the cost? That's a very personal issue at the end of the day, and I won't go into costs today unless there are some in the question part, because that it's priced very differently around the world. But I'm very aware that it's quite expensive compared to an IVF cycle itself. And then a few other things to consider, certainly from a point of view of coaching and support aspects, the things that most of the things I deal with my clients, that could be about any subject, but they're sort of writ large when we talk about PGT-A, because they become very, very apparent with something as sophisticated and I'm going to use the word add-on. I don't like the word add-on, but added on to an IVF cycle. And then very briefly, we can talk about potential next steps for you. So let's crack on and ask the question, what is PGT-A? So it stands for Preimplantation Genetic Testing for Aneuploidy, and that's a new or relatively new nomenclature or naming system, because it used to be called PGS, Preimplantation Genetic Screening. And in a sense, it still is a kind of screening test, but the WHO decided that anything where you test an embryo should be called PGT and then just have another letter that follows. And today we're talking about the one that's to do with aneuploidy. So preimplantation kind of does what it says on the tin. It's at the preimplantation stage, so before an embryo actually goes inside the body. It's a genetic test. We're looking at chromosomes in this case, the way that genes are packaged. And it is a test, but it's not really considered a diagnostic test. It's more of a screening test. And then we've got this word aneuploidy. Well, another word or another phrase you could use is chromosome abnormality. And although the test isn't specifically looking at female age-related aneuploidy, the reason I've put female age-related is because that's the predominant cause of aneuploidy in embryos. It's usually down to having an older egg from an older patient. So we can say roughly 85 to 90% of aneuploidy seen in embryos come from the female side. But as I said, the test, unless you have a special test, it doesn't discriminate between those two things. But female age-related aneuploidy is the most common cause of IVF failure. So that's the why of this. That's why we're looking at it. And this kind of embryo testing, its real aim, there's lots of different nuances to it, which we'll go through, but its aim is to identify embryos with either a normal set of chromosomes or an abnormal or aneuploid set of chromosomes. And the other word we use for normal is euploid. So aneuploid and euploid, but they're sort of interchangeable, aneuploid and abnormal. And then our aim really is to selectively transfer or do something further with normal or euploid embryos. And the aim of this is to increase success rates, and that can mean a lot of different things. See coaching elements, see webinars on understanding success rates, and reduce adverse outcomes. And there's many of those. And when we get into the benefits part, we can talk about what specifically we might be trying to reduce in terms of an adverse outcome. So as I said, I'm going to just sort of do a very high level overview. If you've got very specific questions at the end, that's absolutely fine. But I didn't want to get bogged down in too much detail. And we've got this nice sort of image that I grabbed off the internet. It's not a photo, it's just an image, but it quite nicely shows the process of doing a blastocyst biopsy, so an embryo biopsy to obtain cells for testing, and then leaving the rest of the embryo intact. So we can either do a day 3 biopsy. That's how this process, this technique started, but most countries in the world don't do this anymore. It's mainly at day 5 or day 6, a blastocyst biopsy. And that biopsy, as you see the cells there, something like 3 to 5 cells, it could be a little bit less, could be a little bit more, are taken from the blastocyst up here, which should have, can have anything from 60 to sort of 150 cells, but let's say an average of 100. So we're taking really quite a small percentage of those total cells, putting them inside a tube that's got some special buffering medium in it, and then they get sent to the reference lab or the testing lab, which is usually a different lab from the IVF clinic, but sometimes they're within the same building. And then a test is done, and there's lots of different tests that can be done today. But over the years, this test has evolved. The technology itself is very accurate. What do we mean by very accurate? Well, when you do the kind of validation studies, you're not using embryos, you're doing cells of a known chromosome type. It's more than 99%. In practice, we say it's about 98%. And obviously, on an individual case, it could be lower or it could be 100%. But a really important thing to get into your minds right now is, no test is 100% accurate, and PGT-A isn't either. The other important point is the test itself is not standardized across labs. So there isn't one test that's being used worldwide in every single laboratory. So we're always comparing apples and apples. We're not. There's differences between them. And by and large, they'll give you the same result from the same embryo. And this can be proven by doing a thing called external quality assessment, where a professional body will send out samples of known chromosome status from from a skin cell, for example, they'll send it to lots of different labs and they'll say, can you give me the right answer? So that's a really good way of seeing whether the technologies in the laboratories can deliver the same answer every time. And by and large, they're very, very good at that. But the point is, when we get into the nuances, as we'll see in a minute, the slightly different results, the ones that aren't absolutely 100% clear, then that difference in the laboratory technologies and policies can make a difference to what result you get. And that's where that's where a lot of the controversy lies, at least amongst people who provide this test. Then we've got the genetic report itself. And that, again, there's not standardization. There's a lot of, when you use these external quality assessment tests, you can get a lot of the information to be presented in the same way, but there's still differences in terms of policy decisions. So the interpretation and the embryo classification isn't completely standardized. And again, we're not really talking about when it's fully normal or fully abnormal. We're talking about the gray areas in between. And then I've put on the last bit, transfer of healthy embryos. Well, healthy is not the best word to use, I would say. Ultimately, our aim is to transfer the likely normal or euploid embryos. And meanwhile, the embryos themselves, when the test is being done, are staying in the safety of the IVF clinic. So they're in an incubator, and then they're frozen. So most PGT-A today, when we do it on day 5 or day 6, requires a frozen embryo transfer. So it's good to understand that complete process, because if you had a particular concern about freezing an embryo, then you'd have to know that PGT-A in most cases requires that. So just a brief aside about who I am. I mean, I'm sure some of you have been on my webinars before. This is not so much a sort of bragging contest, just to say, here's where my expertise lies. So I'm still a registered clinical scientist specializing in embryology. And really my whole career has been specialized in this PGT, so testing of embryos. I've got more than 25 years of experience, lots of publications, and still do a lot of scientific reviewing. So I try and keep up to date with all the latest advances. And I've had lots of different roles: clinical, commercial, academic, regulatory, all in IVF. And I think the reason that's important is because when we take something that still is quite controversial, at least in the UK and certain European countries, like PGT-A, then having sat on different sides of the fence, the testing side, the clinical side, the practitioner side, but also the regulatory side, I think I've got a good opportunity to see different points of view and why certain stakeholders might not be as happy as they could be about the way things are done. Worked in lots of different countries, certainly in my industry roles, so I've got more of a global perspective. I'm fully aware that certain things are allowed in some countries and not in others. And I've been involved in the journeys of many patients, so I've seen lots of different scenarios. So I'm happy for you to throw your different scenarios at me. I may not have an instant answer, but I'll certainly be able to find a way to get one for you, and maybe connect with my big network of other embryologists and scientists to try and get you an answer. So let's talk about the possible benefits of PGT-A. And remember what I said at the beginning, they're only possible. They don't necessarily apply to all patients for every time PGT-A is done. But this is one of the claims, and actually there is evidence that this is true. Increased success rate per embryo transfer procedure or embryo transferred. And this is because we're selecting the embryo. We're making sure we've got the embryo that has the best chance of succeeding. And the reality is, if you have a chromosomally abnormal embryo, there's really only 3 main outcomes that you can get from it. One is it just stops growing and doesn't implant. The second is you can have a miscarriage. And the third is you can have, in very rare cases, a child with a chromosome abnormality. Okay, so usually a chromosomally abnormal embryo, certainly a fully chromosomally abnormal embryo, just leads to an adverse outcome. So it stands to reason that if you avoid those and choose the ones that you think are normal, that's what the test has said, you should increase your success rate, whatever you use as your measurement of success rate, per embryo transferred. And don't forget, that's not the same as for the whole cycle started. You should be able to, by the same reasoning, reduce your miscarriage rate. And many studies have shown that, at least for certain patient populations. And you should be able to reduce the chance of a baby with a trisomy, that's having 3 chromosomes of a particular type. In this case, I've used an example, chromosome 21. If you have 3 of those, you have Down syndrome. So these are the possible benefits of PGT-A. And then there's some, they're considered softer benefits, but I think depending on your particular situation, you might not consider them softer. If it's a benefit to you, it's a benefit. So reducing the time to pregnancy or live birth. So in other words, by not transferring all of the embryos, but only choosing the ones or prioritizing the ones that have a normal chromosome complement, you could reduce the time to get what it is that you want, which is a pregnancy and ultimately a live birth. And that means also, another side of that is avoiding unnecessary costs and procedures. So although PGT-A has a cost to it, not doing PGT-A isn't free. That's my little take on it. Because if you end up keeping lots of embryos, freezing them, storing them, transferring them one by one, and they fail each time, then that's not free. That's still costing you. It's costing you in time, energy, and money. And of course, there's lots of procedures to that, which there have been studies in the past when people have had to do multiple procedures to try and get pregnant. They can drop out of the system and say, I don't want to do this anymore. So they've still got a chance, but they drop out because they've got essentially fed up with doing multiple rounds of IVF. So that's a possible benefit. It certainly supports single embryo transfer, because we know that single embryo transfer is the safest way to do IVF. It doesn't mean that not doing it is unsafe. It's just the safest way in terms of the health of the pregnancy and ultimately the baby. So by choosing an embryo that's chromosomally normal, you feel more confident when you transfer a single embryo. And then the final one, which I've had colleagues poo-poo this in the past and said, oh, I'm not sure that's really a benefit. And this is where you've got a lady, usually one who's had lots of failed cycles or is older, who's really got low AMH and very little chance of succeeding, but says, I want to do it anyway. I want to see what the results are, because I kind of need this to know that I need to try a different approach, perhaps egg donation. And I've certainly been involved in cases where you could pretty much predict what the result would be because of the age of the patient. One patient was 49, for example, and we said, I'm absolutely convinced we're going to get all abnormal embryos, and we did, but it created some closure. Okay, so I think there is potentially benefit to that. So then we talk about definite limitations of PGT-A. Well, it's not 100% accurate. No test is. I've already said that. And the corollary of that, or the result of that, is that abnormal embryos sometimes aren't detected, which could lead to adverse outcomes, which I've already listed what those could be. And then I suppose more importantly, I think this one is what bothers people more, and understandably, is that normal embryos or largely normal embryos could be classified as abnormal and therefore potentially discarded. And there's no question that has happened over the years of PGT-A being used, is that some embryos have been classified as abnormal, maybe not fully abnormal, therefore they haven't been used, and that means a chance has been lost. And I think that's why I told you about the standardization and the policies, which isn't just the biology and the test itself, it's how we use that information, because that can really change the outcome of what happens, the choices of what happens when you do PGT-A. PGT-A doesn't guarantee a healthy baby. I mean, it puts the odds very much in your favor, at least in terms of chromosomes. But because it's not detecting other problems that are non-whole chromosome or non-chromosome at all, they're gene mutations, it's not guaranteeing a healthy baby. Okay, but it's certainly putting some odds in your favor. And of course, one of the bad outcomes that's not even to do with a pregnancy is you might not even get any embryos that are of sufficient quality to biopsy, freeze, or transfer. And that could be quality, that could be something to do with the process itself, or could be in terms of transfer at least, there's nothing found that is chromosomally normal. So those are the risks and limitations. And then a really important thing to know is that when you're testing these embryos, you're not improving them. You're literally just looking at what they are. So you're not improving the embryo quality, and you can't increase the cumulative live birth rate. Sorry to throw in this long statistic, but what this means is if you transferred every single embryo in a cohort of embryos that it produced, you could get a certain success rate. If you test them, you can't get a better cumulative success rate. You could only equal it, but in fact, you might not even equal it. So we're not aiming to increase the cumulative live birth rate. We're aiming to increase or reduce the time to pregnancy and increase the live birth rate per embryo transfer or transferred. And that's really important. That's where understanding success rates and statistics is super important, particularly in PGT-A. So I won't go into this too much, but I would say this is where most questions come. It's about understanding the results. And, the clinics and more the testing labs have to take, some blame for maybe not making this clear enough, because I guess part of it is we didn't understand the science well enough. It's improving all the time, but it's still evolving. So you will still see differences between labs. You'll still see even the same lab. If you looked at a report from 5 years ago, it would look quite different, or it could look quite different. So as I've said already, there's really the two main classifications, euploid or normal. And what does that mean? It means that it's likely to be normal. It's very likely to be a normal embryo. And the recommended action is transfer. Then if you get an aneuploid result, well, it's very likely to be abnormal, depending on the particular test used, depending on the thresholds used. And the usual result of that is for it to be discarded. Now, if we get into this grey territory, and the reason I've only put one line is because actually it becomes quite complex. This grey area of mosaic, and I've got a little image of a mosaic embryo down here, or a sort of schematic, where instead of having just a cell type of one colour, which is representing, normality or red abnormality, you've got this sort of patchwork effect, a mosaic effect. And of course, that means if you take cells from, here, you're going to get a mixture, and it's going to be a mosaic result. If you take cells from here, it will appear to be normal, when in fact it's actually mosaic, which could mean it's more normal or less normal, but we couldn't tell from just those few cells taken. So you can see it's quite a complex issue. So the answer on what's the interpretation is it depends, and that's changing all the time. And then the recommended action, because of that interpretation, is also it depends. So I would say a good rule of thumb here, though, is if you have a mosaic embryo, unless you're getting some very, very clear patient information at the beginning and at the end of your cycle, is to get some genetic counselling if you've got a mosaic embryo, because then you can get somebody who's a professional who's up to date on all the information about mosaic embryos. Even if your embryo was tested a few years ago, the new information should help to help you decide what to do with that embryo. And the truth is, a lot of those embryos have been discarded or not yet used, and perhaps some of them should have been, okay? Or almost certainly some of them should have been. And the clinic and testing lab technology and policy can have a big impact on what this mosaic result looks like and how many embryos actually appear to be mosaic. So there's quite a variation amongst laboratories. And that tells you something. That tells you that it's not all a biological reality, just part of it is. And then this is an important one. I'm often forgotten when talking about PGT-A results. Getting no result. So if you get no result, it's as if you never did the test. Now, don't forget, some of you might have thought, I wasn't going to do PGT-A anyway. So you're back in that position where you've got an embryo, you've got your age-related aneuploidy risk, which is still the same. Nothing's changed just because you took a biopsy from that embryo. And you can make a decision whether you want to, take the risk of having an adverse outcome, or indeed take the risk of it actually working without having to get a test result. So you can retest to see if you can get a result the next time. You can transfer with the risks, or you could discard. I don't think discard is necessarily a very good idea unless your reason for doing PGT-A at the beginning was absolutely to avoid a miscarriage. And then there's this other result, chaotic, and I'm not going to spend too long on it because I think this is one of the ones that's been the most confusing. If it's a high rate of chaotics in a center, and that's one of those frequently asked questions you should always ask, then I think that's potentially a problem, because it's easy to say, oh, it's patient specific, but there's a good chance that it's something to do with the testing methodology or the interpretation of results. But by and large, in the past at least, in a lab that has a very solid test, this is likely to be abnormal. So it's chaotic, meaning it's got lots of different chromosome abnormalities present. So very small chance to be normal. But the reason I've said small chance is because there is a chance. And in some of the test methodologies that have been used in the past, chaotic actually meant this is hard to interpret and it could be normal. So I think that's a definite candidate for retesting. But that's something to ask your clinic, and that's for them to ask their laboratory. So who should consider PGT-A and why? Well, the traditional clinical indications for PGT-A, they haven't really changed much over the years, to be honest. But the sort of number one is advanced maternal age, because of that age-related aneuploidy, which really nobody disputes. Even the people who don't think PGT-A should be done, they don't say, oh, we don't believe aneuploidy is present in women of advanced age in their eggs or the embryos. They absolutely agree that's present. They just say, we don't think your test is good enough to discriminate between likely normal embryos and likely abnormal embryos. We could argue about where that advanced maternal age cutoff is. In some regions in the world and in some laboratories, that's considered as over 35. In others, 37. In others, 38. But I think you get the picture. It's when they start thinking your chance of having more abnormal embryos than normal is higher, then that's what they consider advanced maternal age. Severe male factor infertility, there's some evidence that that can have an impact. Although, as I said right at the beginning, aneuploidy tends to be more a maternal problem than a paternal problem. But that doesn't mean it's not related to, it's never related to the male. Sometimes it is. And then repeated miscarriage or implantation failure. So since those are two of the adverse outcomes that we're trying to avoid, it stands to reason they could be indications for doing this test. And then I've put this in bold because this isn't a traditional indication, but in some clinics and countries, this is offered and or performed on every patient. So it sort of throws out the window the indications. It just sort of, it's a bit like saying, well, since aneuploidy is a potential problem for all patients, which it is, but to a greater or lesser extent, depending on their age, or generally their age, then, is it really the right idea to do it for every patient? And I'd like to sort of, kind of nuance that a bit and say every patient has a unique scenario, or perhaps more importantly in this case, a unique need. So they might say, well, you know what, I don't want to risk biopsying and having to freeze and potentially having nothing to transfer. So there's a patient need versus the actual biology there. So I've just used a couple of examples. I've just made these up, but just to show how, although you're using the same test, doing exactly the same methodology for two different made up patients, there could be a very different reason for using the test. So we've got a patient at the top there. She's 29 years old, would be considered, on the younger side. That means in general terms, she'd probably have more eggs. In general terms, they'd have less likelihood of being aneuploid. In her reproductive history, very broad brush here, her partner needs ICSI, it's male factor. So there's really no other thing that the doctors are concerned about. So in her journey, she's got high AMH and she can make 15 blastocysts. So in this case, you could say, well, maybe she doesn't need PGT-A at all. So I'm not saying one way or the other, she should do it, she should not do it. I'm just saying, what does PGT-A mean in this scenario? Well, it probably means selecting one euploid embryo for transfer. That would be the benefit, if you like, the potential benefit of doing PGT-A. She could also take her chances, and I think she would have very good chances in that scenario. Then we've got a lady who's 43 years old. Her reproductive history is she's had a previous child, but she's also had multiple miscarriages recently. On her IVF journey, she's definitely got low AMH, and that's meant that she can only produce one blastocyst. So I've spoken to many doctors who've said, oh, well, I wouldn't even do PGT-A there, and I wouldn't even recommend it to her, and we wouldn't even talk about it. But the reality is, depending on what her need is and what her reason for doing it is, she might say, I want to do PGT-A to avoid miscarriage because I've had miscarriages before. And not just the trauma of miscarriage, but the time spent, potentially the medical ramifications of having a miscarriage. So she's doing it not to select an embryo, but to avoid having a miscarriage. So I'm just trying to make the point there are different, for the different benefits, there are different patients who want it for a different reason. And I think that's really important to understand. So is it worth the cost? And, we could talk about cost in the Q&A, but I didn't want to throw loads of costs out. I think probably some of you have already looked at costings. But given that there's some evidence that time to pregnancy can be reduced, and that also means fewer procedures, and the overall cost, therefore, could be reduced with PGT-A, even though it has a cost itself. So even though it's an extra cost on top of doing an IVF. But ultimately, it's your choice for your specific situation. I think that's really important. Obviously, in studies, it's done on a statistical basis, but in your particular case, you have to weigh up the pros and cons of doing it, what your budget is, and so on. And you can, and my opinion here is that you can only make the right choice after you've received all the relevant information. And that's tons of information, by the way, but I've just put some examples, your age, your specific age-related success rates, the costs that you've been offered, and so on. So these support and coaching considerations, I guess I would say these are true of every aspect of IVF. And I've had clients with, going through all different situations. But in terms of PGT-A, I think some of the things that I normally talk about in my coaching, which is, for example, and the common questions, how to choose a clinic. Well, that's super important for PGT-A because you need to know whether the clinic does the test or not, what its experience is, what its cost is, and what its success rates are. The usual questions. You have to definitely have your boundaries nicely set up here, because there's going to be a cost implication which might exceed your budget, and you've got to be able to say no and not just feel like, if you want to say no, by the way, versus feel like, oh, this clinic does it. They say that they do it for every patient that's like me, so I feel like I have to do it. You don't have to do it. It's good to understand success rates, because when you add in the further complication of PGT-A, this extra test, this extra selection, then you really need to understand the success rates properly, what's being compared with what. And you really do need to hone your bullshit detector for PGT-A. And I've said bullshit today because last time I said BS and people were saying, what's BS again? One size doesn't fit all. That's the truth here. And lots of claims are made about PGT-A, and I'm a believer in it, but I don't like it when excessive claims are made. And then, of course, decision-making, which people often need help with. Should I do PGT-A or not? Or should I transfer an embryo or not? That's a common one that I get with clients. And, I think being independent but knowledgeable about this helps me to help them make the decision that ends up being right for them. So you don't have to be told what to do. You can think through all the information you have and make a decision, make an informed decision at the end. And of course, asking the right questions, because adding this extra layer onto IVF means you have to become a mini expert in this as well. And then some other things to consider, just for sort of interest, really, but these are coming up fast with the advances in technology. Is the future of PGT-A non-invasive, so not having to take a biopsy at all, just taking the growth medium that the embryo grows in? There's lots of advances in that, but I think everyone would agree today it's still not exactly the same level of accuracy, but maybe there's a different reason for doing it in a country where you can't do a biopsy. Or if you just want to prioritize, and you're going to transfer all the embryos anyway, but you'd like to prioritize, but you don't want to do biopsy, might be a good alternative. There might be some other biomarkers, not looking at the chromosomes, that might be related to a proxy for aneuploidy. And people are working on using artificial intelligence with the morphology to see if there's any strong relationship with aneuploidy. So you don't even have to do a test. Again, I would say these are prioritization type tools rather than absolute selection tools, but there's a lot of work going into that. I would say, one of the best things you can do for yourself, if you have any questions about PGT-A, if you're going through it, and any questions about your results, is to speak to a bona fide, like a proper genetic counselor, because they're non-directive, they won't tell you what to do, and they'll really talk through the basics, understanding what you've been through, and the information you get at the end, which can often be a bit of a surprise. So difficult results, for example. Pricing strategy is really important. I think these days, I'm a little bit shocked if people are still charging people by batch of embryos when they might only have one. Again, a reason why somebody might not do it if they only had one embryo, which just seems a bit ludicrous. So I think it should be per embryo pricing, but I don't get to choose what clinics do. And then batching of cycles. So, doing multiple rounds of IVF before testing or using an embryo. And I think that's something for discussion, because you have to ask yourself the question, who's the strategy really benefiting? Is it really benefiting you? Or does it also mean that the clinic gets to do multiple cycles of IVF? And I've said earlier, doing no PGT-A isn't free. There are additional procedures that cost time and money. So you have to consider that. And as I've said all throughout, clinic and the testing lab can influence the results. So it's not just about the test itself and the biology, but the decision-making, the interpretation. And that's why you need to ask a lot of questions if it isn't as simple as an abnormal or a normal embryo. I've put some resources here. There's some nice articles in Fertility Road. I've written one that they asked me to do, and that's sort of formed the backbone of this talk, which you might find helpful. If you're in the UK, or even if you're not in the UK, you can look up the HVA's version of PGT-A, which I would say is on the more sober side, on the more negative side. I'm trying to be balanced, they're trying to be balanced, but one always brings a certain level of bias to the table. And I'm putting my hand up and saying, I have a bias towards thinking it works. A really interesting article, which is quite readable in Reproductive Biomedicine Online. One of my colleagues wrote a really nice review about why PGT-A, given all the evidence that we have, some of which is good, some of which is less good, most likely improves IVF success. That's quite a nice article to read. And then if you're struggling with results, there's a really nice YouTube video to watch that's where they explain the PGT-A results but by a genetic counselor. So that's quite nice, and I'll put the link for that in there. So I leave you with, if you're planning, having, or have had PGT-A and you still have questions, why not book a call with me? Or why not get in touch with a genetic counselor? Now, just to say, not all genetic counselors will talk about other people's tests. So that's just a little caveat that they sometimes say, well, I will only talk about the tests that I'm familiar with, that the lab that I'm involved with does. So I don't think you've got any obligation or anything to lose. You'll almost certainly learn something, and you'll probably save some time and money. Thank you and good luck. And I'll leave you with one story about, a patient I helped who had a mosaic embryo. She wanted to transfer the embryo. The clinic had said no, or at least that's what she told me. And so I didn't call the clinic. I just said, right, how are we going to deal with this? And I said, you need to speak to a genetic counselor. She spoke to a genetic counselor. They had a good discussion. She was very happy. The resolution of the conversation was that she would indeed transfer the mosaic embryo after understanding all the risks and benefits and everything else. Unfortunately, the letter didn't say that little part of the conversation. And she got very anxious and said, I think something's wrong here. That letter was supposed to say this. And of course I wasn't there, so I didn't know. I just said, do you know what? Before we get into conspiracy theory mode, I think you just need to contact that counselor and say, do you remember that conversation? Could you rewrite that letter? She rewrote the letter. They went back to the clinic. She transferred the embryo. So, sometimes this isn't about the science and the medicine. It's about how to navigate the system. Okay, so I'll leave you with that. So I'm really looking forward to taking your questions, and thanks for listening.
Brilliant. Thank you so much, as always. And it's been an interesting presentation, and thank you for explaining all the steps and all the parts about PGT-A, obviously. As you can see, there are plenty of questions already here, so I know it's your favorite part. Thanks everyone for your questions, and of course we will have like around 20 minutes for those. Some of them are really long, so we will try to, we will do our best to answer them. However, remember that sometimes we might require also a little bit more information, okay, to give a proper answer. But we've done it before, right, Alan? And we are ready for it. So
yeah, we'll go for it.
Yeah, let's start with the first question. Interesting one. So a friend mentioned that at 35, I'm 35 years old. Even with endometriosis, adenomyosis, I must not be tested because in that age area, usually the embryos are euploid. What do you think about this? We always have day 2, 3 good embryos, but they don't get to a blastocyst stage or have poor quality. What's the alternative to PGT-A when having this blastocyst problem? Can you help us?
Okay, so I know there was only one question, at the end, but I'll sort of introduce a question for, earlier, where it's like, because we're young, so we've probably got euploid embryos. All I would say there is on the balance of probability, that's true, but you can't rely on that. There we go. Oh, sorry. Yeah, you can't rely on that. So all I'm saying is, although you're most likely to have more normal embryos if you're younger, there are young patients that have lots of abnormal embryos, and there are older patients that have at least a few normal embryos. So I wouldn't sort of have ruled it out. But the problem is I think you said you're not making blastocysts. So at least in terms of the test, which is normally done, which is growing to blastocysts and biopsying it, that's going to make it very difficult for you. So that's I should have actually said that's, I suppose, another limitation of the test. Well, I did say if you don't get to biopsy. So I think in your situation, given that you don't necessarily have a high risk of aneuploidy, then transferring the embryos earlier, potentially at day 3, is maybe the best thing you can do. Or if you've gone to multiple clinics and you never make good blastocysts, there could be some underlying problem there. If it's only one clinic, it is an idea to potentially go somewhere else, have different stimulation, experience a different, your embryos experience a different culture system, and it's possible that they might make it to blastocysts. But one thing I would say is, your aim in IVF isn't to make it to do PGT-A, certainly not at your age. Your aim is to get embryos to transfer. Okay, so that should be, in your situation, that should be your primary goal. And I think you've sort of recognized that in your question.
Okay, brilliant. Thank you so much for that advice here. Next question from Daniela. So I have suffered miscarriages before, just turned 40. I have never had issues conceiving. I have a living three-year-old. As an unfortunate February, I had TFMR due to a T21 diagnosis that was not down to our genetics. Would you recommend going the IVF route with PGT-A included, or simply trying naturally again?
Okay, so I'm trying to think of a lot of things here.
Sure.
So if you said you had multiple miscarriages, one of the important things, although chromosome abnormality is one of the most common causes. Oh, there we go. Nope, that's the old question.
Sorry.
Yeah, that's okay. Although chromosome abnormality is one of the most common causes of miscarriage, it's not the only cause. And for a particular patient, it might not be the cause at all. So if you're concerned about miscarriage, you should definitely have a miscarriage workup, which will be looking at, all kinds of different endocrine factors. You get a proper workup that doesn't focus on chromosome abnormalities, because that might not be the problem. Although it probably would include having your chromosomes and your partner's chromosomes tested to make sure that wasn't an underlying problem, which, in a certain percentage of the population, probably less than 5%, but that could be a problem. So I would definitely consider that. But saying should I go through IVF when I don't have a problem getting pregnant, I would say if you're even considering IVF, before you do that, definitely get your chromosomes tested, because you'd be, if you're going to go for all that extra intervention, you might as well do a test to rule out something that would, if you've got abnormal chromosomes, translocation, you've got a high chance of having abnormal embryos. And so that would potentially be a problem. But I wouldn't say you're definitely in the mix for doing PGT-A straight away. When somebody has a miscarriage or even a trisomy 21 pregnancy, it doesn't mean automatically that their risk of having the same in the next cycle is really high. That's what the stats say. But then there's this thing about need versus biology. Some people say, I don't want to go through that again, so I'm going to take all the intervention steps to avoid that happening. And certainly doing IVF for PGT-A would, massively reduce the chance of having a miscarriage or an aneuploid pregnancy. So I hope that helps.
Okay. I'm sure it's been helpful already. Thanks a lot again. Next question from Nina. I'm 44. I have 2 fertilized eggs that reached the blastocyst stage. Considering my age and the low number of embryos, should I transfer them both or proceed with PGT-A?
So can you say the age again? I didn't.
44. 44.
Okay, so 2 embryos. There was two embryos.
Yes,
should I?
2 embryos.
And are they
transfer
frozen?
them both or proceed with PGT-A?
Okay, are they already frozen then? I'm guessing they must be. Otherwise, I guess you can't really talk about having 2 embryos.
Yeah, sorry.
If they're already, that's fine. If they're already frozen.
No, they are not. Okay.
Oh, so this is happening in real time then?
I think so, yes.
Okay.
As the answer is no here.
Okay. So if it's happening in real time, I think your decision making should be around what's happened in the past and what your attitude and concern is surrounding a miscarriage. Because as I said, you actually fit very closely with the sort of fake patient that I put in my slide deck, where I said she's 43, she's had a pregnancy, she's had a child before, she's had some miscarriages. What should she do if she only has 1 embryo? And she might choose to do PGT-A to avoid miscarriages. So that's, because your chance of having a child with a born child with a chromosome abnormality is actually quite low, but your chance of having miscarriage is really quite high. But the most common thing that would happen if your embryo was aneuploid is it would just fail. You'd have a failed implantation, which wouldn't take up too much time. At least a miscarriage would definitely take up more time in your reproductive journey. So that's the thought process. There isn't an answer. There isn't a kind of like, this is what you must do. It's a conversation, a discussion. And I realize if these are embryos growing in the lab right now, I know you don't have a lot of time to think about that, but that's the value of trying to think about these things in advance. What if scenarios. You could defer this decision by freezing them. The only downside of that would, without doing anything, without transferring or doing PGT-A, but if you freeze them, you're going to have to thaw them again and biopsy them. And although that works, it's probably less, less good than just doing the biopsy straight away and then freezing it. But they're going to get frozen either way unless you transfer them fresh without any testing at all. So, definitely have a good conversation with the clinic and ask what their success rates are with patients of your age, with and without PGT-A.
Okay. Yeah. Thank you. Hope that helped again, Nina. And yes, Nina says thanks for your answer as well. And let's have a look. Now we will go to a longer question. Okay, let me just show you this. I think it's best to do that. There are a few questions in one. So let me display it here. So as you can see, I'm explaining fertility for 3 years. We got 8 blastocysts from our first cycle with PGT-A, only 5 embryos, called euploid, mosaic loss, and mosaic segmental loss. And there are 3 questions here. The first one is, doing hysteroscopy and ERA test may increase the success rate of that only one euploid embryo transfer, or is there any test which I can do that can increase the success rates of euploid embryo? Let's get this.
Okay, that's great. I mean, it's really long, but it's really helpful seeing it. So thank you, thank you for that, and it's really clear. So thanks for thanks for writing such a clear question. Okay, so let's start with the first thing. You've got a euploid embryo, and you want to increase your chances of success with that. So that's absolutely reasonable to say, doing something like hysteroscopy, and if you've not had that before, and a receptivity test, plus or minus microbiome testing, by the way, to make sure that your the lining of your uterus is conducive to having embryo implantation. And I would say that there's a good reason to do that, because you've already invested a lot in trying to create a euploid embryo. Okay, so understandably you want to give it the absolute best choice, and I think that's a really good example of when you might want to do that. But obviously ask for all the information, ask for all the success rates that the clinic has got, ask whether they are using ERA or equivalent test in their practice normally. So those are probably so you've highlighted those tests. They probably are the things you could do. I'm not recommending, I'm just saying those are things you could consider to give yourself the best chance. The mosaic embryos, let's get to those. This is definitely a case of good idea to definitely speak to the clinic, who should have information from the lab. Depending on the lab, most labs that I know, I don't know what country this is in, but most labs I know have genetic counselors attached to the lab. So this is definitely worth speaking to a genetic counselor about this. Okay, so looking at this mosaic embryo, I mean, I didn't go into all the detail because I didn't want to turn it into a mosaicism talk, but depending on the degree of mosaicism, the particular lab that's done the testing, the chromosome that's involved, these can all have an impact on whether this embryo is actually more on the side of you might as well transfer it, because the worst that can happen is it just fails. And I'm not making light of that. That's not a nice outcome, but it's not leading to a miscarriage or a child with an abnormality. Or actually it's basically normal, just had a few abnormal cells that were detected, and you should give it a chance to transfer. So that's very similar to the story I told you about the lady that I worked with. I don't know that it's the same chromosome. I don't know it's the same lab did the testing, but I'm making the point that mosaic embryos shouldn't automatically be ignored, discarded, or not used. You should take them quite seriously. And the same goes to a degree with the mosaic segmental loss. Again, it will matter about the size of the loss, the chromosome that's involved, how confident we are about the result, because rebiopsy is always an option. I'm not saying it's the best option, but it is an option. So I wouldn't write off those other 4 embryos, and certainly not the first 2, the mosaic loss. So that's number 2. And then the final one, we still have 3 more embryos untested. So I presume that they're already frozen, probably frozen at the blastocyst stage. You could have those tested, depending on the age you were at when those eggs were harvested and those embryos were made. That will give you an age-related aneuploidy.
All right. The patient here added, right, that she is 33 right now. 33. Okay. AMH level is 1.8 nanograms as well.
Okay. So really, it's that decision-making process where you say, how much time have I got on my side? Because it's someone who's 46 or 45 says, should I transfer the embryos or should I, make some more embryos? It's a different situation because they haven't got time on their side. If you're 33, you have at least got time on your side. So your decision-making algorithm in your head, if you like, is to do with, am I wrong word, but am I prepared to transfer an embryo knowing there's a risk of having a miscarriage? Maybe a small risk in your case, or do I want to get all those embryos tested and deal with the results then? But based on what you already got, not that you would get the same results, but based on what you already got, you only got one in this cohort, the first one, you got 1 out of 5 embryos where you got a clear result where you said, oh, I know what I'm going to do, transfer the embryo. With these 3, you may not get a clear result. They may all give you a result of mosaic. So you've done a big procedure, a lot of cost for not really much help, because as I've said, if they're mosaic, you may end up transferring them anyway. So again, I'm not giving you the answer, but I think you could seriously consider transferring those embryos without testing them.
Okay. Again, thank you so much, and hope that helped. Sorry, it's not me doing this today, I'm afraid. So it's the same questions. Of course, we will go to the next one. So it's actually the question from the first patient, Larissa, who asked about the. So let me just go get to it. So it has to be mentioned that although I had 10 transfers with the 4XE, there was not one that implanted. My husband has asthenospermia. I just recently read that when the embryo doesn't develop after day 3, it's pretty much because of the poor sperm quality. What's your opinion? We are open to sperm egg donation, but until up to now, every single doctor said we can still try with our own material. I am really tired and sad through. Though after 2.5 years of ICSI and cryotransfers without implantation, I wish we could be sure which part we need, whether it's a donation or, but there's a real test for that, right?
Okay, great. So yeah, the problem with this is where the bullshit detector has to come on, full, is people have to be a bit more honest about the fact there's lots of things we still don't understand. So the kind of glib answer of, if your embryos don't develop, it's probably down to the sperm. I really don't think there's strong evidence to support that, meaning there could be much more to it. There could be a genetic component from your partner. There could be a genetic component from you. If you keep seeing it, it starts to suggest some sort of genetic component. As I said at the beginning, unless that laboratory has a particular problem with that, but that's unlikely. So it does seem like, that's a problem that's specific to you as a couple. I think we're a way off, not that far off, maybe 5 years off, understanding why we get this embryo arrest, let's call it that. Embryos don't grow as they should do, either in the body or in the incubator. And the truth is, I said transfer at day 3 if you're not making good blastocysts, but if your embryos never go to blastocysts and beyond, maybe they won't inside the body either. So transferring and putting them in the body isn't necessarily going to help. But I think this is where we come away from the biology and the medicine, and we say, do people really want to keep doing IVF in the same way, i.e. using the same sperm and the same egg 10 times and hope for a better result? And that's when you do need to, you've said you're open to the suggestion of sperm and or egg donation. And I think that's an important factor that you have to consider, because when you've done that many cycles and not had a glimpse of sunshine of something working, it's time to think, what can we do to try and really increase our chances? So maybe a kind of taking a big step backwards and going, okay, let's really look at this. And I'm a little worried about, which is when I host the Ask Your Doctor sessions, I always put the doctors on the spot and say, has this ever worked at your clinic? Right? You can talk about the science, the statistics. Has it ever worked at your clinic for a patient this age, for example? And if they say no, I say to the patient, there's your answer, isn't it? I mean, it's great to believe in miracles, but I don't think we're in the business of miracles. I think we're in the business of things that have a high chance of working. And for example, egg donation has a high chance of working for most people. So if that's the problem, then that's there's a solution that's there. But that's it's a big mind shift do to start looking at either sperm donation or egg donation or both. It's it's a big deal. But just saying, oh, we could try it again, I'm not sure that's necessarily a good idea.
So clear. Thank you indeed for that. All right, more questions are coming in. Let me have a look at the one from Cynthia. She'd like to know your interpretation of doctor's description. So let's have a look. An endometrial biopsy was taken and sent for pre-implantation genetic testing, but unfortunately the DNA failed to amplify, and hence we have no results from the biopsy of the embryo. So initially the word chaotic was being used, but now it seems not. Thanks.
But did you say? I thought I heard endometrial at some point. We're talking about
endometrial biopsy. Yeah, endometrial biopsy was taken and sent for pre-implantation genetic testing, but unfortunately the DNA failed to amplify, and hence we have no results from the biopsy of the embryo.
Okay, I'm a little confused about that question, because an endometrial biopsy, which is used for receptivity testing, for example, is completely different from a pre-implantation embryo biopsy. So unless that means an embryo biopsy, okay. So DNA. DNA failed to amplify. Let me assume it's an embryo biopsy. Otherwise, I'm very confused. So embryo biopsy, the result that they get sent back is the DNA failed to amplify. Usually, that's a technical error. And it's not someone's to blame. It's one of the low chance of something not going well. So you take some cells from the embryo. It's possible that there's no nuclei in those cells where the DNA is. It's possible, but that's unlikely. But it's also possible that those cells never managed to get into the tube, and therefore when you test, there's nothing to amplify. So it's as if you never did the test. It's not intentional. It's just a rare thing that can happen. The other one is there are cells in the tube. There is DNA in the cells. But the test itself doesn't work on that tube or in that run. Those are all questions you can ask the clinic to ask the testing lab, just to rule that out as a possibility. So, for example, this is extremely rare, but for example, if you only had one embryo and it was tested, you got a failed to amplify result, and you asked, you managed to be a fly on the wall in the testing lab, and they said, oh yeah, that happened like 10 times that day. It's probably not your embryo. It's probably the testing lab. But that is very, very infrequent. So all I'm saying is a little bit of detective work, can go a long way there. But the reality is, let's talk about the reality of where you are. The reality is you've got an embryo, it doesn't have a result. What do you do next? So you could either have it rebiopsied. So this chaotic thing is, definitely a red herring, because if the DNA failed to amplify, it failed to amplify. Chaotic is when the DNA doesn't fail to amplify, you get a result, but the result you see is chaotic. So I think I think that deserves a bit more explanation from the testing lab and the clinic, because they're not the same thing. But the result is the same, and that is that you either need to retest, rebiopsy, or just transfer the embryo blindly, meaning we don't have any results on it, let's just cross our fingers and hope. And I don't mean that in a glib way, like there's no chance. I just mean that's anyone who doesn't do PGT-A is doing that all the time. So it's a valid thing to do.
Okay, again, thank you. Hope that answers your question. But of course, if there's anything you would like to clarify, you know what to do. I think that there are more questions coming up. Let me just have a look. So any advice to improve equality? It's actually, sorry, I thought that it was from Cynthia, but it's from Catherine. I think we can still.
Okay, this has been, okay, that's a great question. It's not necessarily PGT-A related, but I'm going to answer it from a PGT-A point of view, because there's been lots of other webinars on diet, supplements, antioxidants, all of which may have some impact on egg quality. But if we speak specifically about can we reverse this age-related aneuploidy, which is the main thing we've been talking about tonight, at present, the answer is no. It's possible there might be some drug therapies in the future that might have an impact on certain patients because of how aneuploidy is formed, but it's not well understood, and we don't have that at the moment. So in terms of turning back the clock, let's use that kind of imagery, I don't think that's really possible at the moment. Obviously, the interesting thing is just having a euploid embryo, doesn't mean it's going to be successful. So there are other factors as well, and they are part of oocyte quality. So just because you're an older lady and you think you have a chance of, a low chance of having a normal embryo, it doesn't mean you should give up on all the other things to improve your egg quality. It's just not necessarily going to change the rate at which you have chromosome abnormalities.
Okay. Crystal, here again. Let's have a look at this question from Sergio. What correlation in aneuploid embryos in the biopsy when you study the inner cell mass?
Okay, well, that's a great question, very technical. When you biopsy an embryo, your aim is not to touch the inner cell mass, as I'm sure you know, because that becomes the embryo proper, the baby ultimately. So you take it from the trophectoderm, these other cells. They're going to end up being the placenta. So they're already, this is cell lines that are already diverging. So it stands to reason that they may not be identical throughout development. But the reality is when the trophectoderm has been compared to the inner cell mass, actually there's very good, it's a very good representation. So I think it's, around the 90%, maybe higher than 90% mark. We looked at this a lot when we were doing the studies on the non-invasive approach. So it's not perfect, but it is a very good representation of the inner cell mass. But we're not getting any closer or wanting to take the inner cell mass. So we're still going with the trophectoderm. The interesting point is whether in the future we're going to be taking just fluid containing DNA that's been released from potentially multiple different sites in the embryo, and maybe that's going to ultimately be more accurate representation of the inner cell mass. But the data we have so far is that it's no better than trophectoderm.
Okay. Thank you for answering this question as well. Helen would like to know, so what challenges do mosaic embryos pose and how can we optimize their chances of successful implantation? Are there specific genetic patterns associated with mosaicism and that we should explore further?
I think the best way to think about mosaic embryos is, as I said, always to find out from a professional what the latest information is, because it has changed over time. In a sense, the embryos haven't changed. In a sense, the test has changed a bit, but not as much as the interpretation. So some great work has been done on the embryos that have been transferred that were called mosaic. And I always say this to patients when we talk about embryo quality. Calling an embryo something doesn't change it, right? You can, you're only doing that so you can make a choice about it. So when you call an embryo mosaic, it's because you got a result that said, I think it's mosaic from the cells that I took. And what this study has done, and it's still not a huge number of embryo transfers, but it's a decent number. It's in the thousands now. The embryos that were called mosaic of various different types, degrees of mosaicism, different chromosomes, so a real mixed bag, they got transferred and then they looked at the results. So now they've got a really nice set of data, some of which says if you have this type of mosaic result, you have a very similar success rate as if it was normal. If you have this type of mosaic result, you still can have a pregnancy and you can still have a baby, but the chance is reduced, but not zero. And then still more information is in rare cases that mosaic result actually carries through all the way to the pregnancy. So it's not just a case of binary success or failure, carries through to the pregnancy and the baby itself. But that percentage is, or that percentage of embryos that are mosaic that get transferred that leads to that is very low. So what's really nice is there's this kind of schematic that's been produced now that basically says, I can't say it specifically for your case and your embryo, but in general terms, if you have an embryo with this result, this is where you fit within the scheme. It's more likely to be normal, therefore transfer it and really don't, monitor the pregnancy, but don't worry about it. It's more likely to be abnormal, make a decision whether to transfer it or not, but know that the risks are still there. But back to that point, if you'd never tested it and you transferred it, you would have had the same risk. So testing it doesn't make it more mosaic, more abnormal. It's not changing the embryo. So you shouldn't worry more than if you hadn't tested the embryo. We're not seeing, since we've been doing IVF, we haven't been seeing children with weird mosaic results. So it's an infrequent problem to consider. This is why I blamed the sort of testing labs of which I was a part. we've kind of, created this problem a little bit by having all this classification. But the classification is getting better all the time. So definitely speak to a genetic counselor about the latest results.
Okay. Thank you so much. Helen would like to also know, so let me go to this one. How do we balance the benefits of PGT-A, lower miscarriage rates, with the risk of false positives, healthy embryos misidentified as aneuploid? What strategies can clinics adapt to minimize false positives?
Okay, well, I'm not going to throw numbers at you because I think it would just gets confusing and they change all the time. But I would say you can do some basic sort of calculations and say, what do we think, what's the testing lab quoting as their false negative and false positive rates, compare that to the chance of having a miscarriage, which I think by and large is going to be higher, and then add in that extra dimension, which is very personal, which is what's my attitude towards miscarriage. Now, I'm not being dumb about this. I mean, I don't think there's any person, any woman or partner of a woman in the world that would say, miscarriage, that's fine. I'm not saying that. I'm just saying in terms of balancing those risks, as you said, you're balancing your attitude to the risk as well. It's not just the number. It's like, how do I feel about it? So I think it's very personal. I can't give you an answer like, one wins all the time. I think if the numbers were massively more skewed, then it would be easier to make that decision. But it's because they're closer and people have different attitudes towards them that makes it a difficult decision. I'm sorry if that didn't completely answer your question, but that's I think it just says you have to have a discussion about it, and you have to go through your own boundaries and think about what matters to you most.
That makes sense. Again, thank you. Indeed. Regarding the previous question, are you able to tell us the name of the study for tested mosaic embryos and their classification?
Yeah, I can tell you the name of the author, which should help, because off the top of my head I can't remember. It's his last name is Viotti, so Viotti, and it would be quite recent. So yeah, I'm not very good at multitasking, otherwise I'd be tapping away in my search bar. But Viotti has published on that recently, and I think he will continue to, because he's got like a registry of these mosaic transfers. So, I should say a little bit more about it. The truth is, of embryos that have been tested and have been called mosaic, there are probably hundreds of thousands. Of embryos that have been tested, called mosaic, and transferred, there's only a few thousand. So you see, we've sort of created the problem of calling them mosaic, but we don't have the information. We don't have enough information yet to say, oh, it's okay. When you get this result, this is what you do.
Okay, I think I might have found this. It's using outcome data from 1,000 mosaic embryo transfers to formulate an embryo ranking system for clinical use. This is the name, right?
And I think
just put it.
That's it. And I think that's super useful and super practical. Now, obviously we'd love that number to be 10,000, 100,000, but the point is it's already starting to show quite clear, quite clear signs of what you should do. And there's nothing scary in there, by the way. And even if there were something scary, my point is it's not created by PGT-A. Whatever it was already there, but now we're putting a name to it.
Okay, true. Of course. Brilliant. Thank you so much. Let me just have a look. There are more questions, of course, here. Let's focus on the ones that are related to our topic today, as there are some other ones as well. So if you can have a look at this one, sorry. So is it worth it for a healthy couple, female is 37, male 42, to conduct genetic testing prior to making embryos to prevent potential disorder? Or is it better to wait for embryos to be made and conduct the PGT-A test to determine the genetic health of the embryo?
Okay, well, I'm gonna. There's two sort of big. There's lots of genetic tests one could do, but in this field, in IVF or in reproductive medicine, there are two really important tests that people can do if they can afford it and they want to, and they've considered the risks. And what I mean by the risks here, because these are very low risk to the patient tests, risks in terms of the chance of getting a result that's meaningful. Okay, that's what I really mean by risk there. There's two tests. Carrier screening is a way of couples, before they even conceive, whether that's naturally or using assisted reproduction, to say, what's my chance of having a mutation in a gene that could cause a genetic disorder in a future child, and what's the chance in my partner. So when those two mutations come together, there's a chance of having a child with a genetic abnormality, something like cystic fibrosis, sickle cell anemia, beta thalassemia, one of these sort of classic genetic diseases. So that's a really important test. And in some countries, whether it's private medicine or in some cases public medicine, that's quite a standard test to do. It's still not standard in many countries. And I'm a bit surprised. I mean, it's obviously a cost benefit thing that's been done. But in studies that we've done and others, we've shown that the chance of having those what's called co-carriage, the male and the female both have a chance of having that mutation and therefore passing those mutations onto the child, which would result in a disease, is about 1 in 50 patients. So then you add in, okay, well, if it's recessive, there's a 1 in 4 chance of having a child that's got the disease. So, that makes it 1 in 200. But that's not a tiny number. And 1 in 50 is, that's the risk part. 1 in 50 is definitely not a tiny number. But actually, in some countries where you have to pay for it, very few people do it. And I would say for the cost of an expensive buggy, it seems like to me like quite a useful thing to do. And I think the problem there isn't so much a wealth gap as a knowledge gap, because people just don't know about it or think about it. And when you go and see your GP or family medicine doctor, I don't think it's the first thing they talk to you about. It's usually about, how to get pregnant. So that's one type of test. The other type, which is much more related to what we're talking about tonight, is a basic chromosome analysis. And in the normal population, as I said, it's really, quite a low incidence of finding an abnormality. It's not an abnormality that makes you have a problem, but it's an abnormality in terms of how your sperm or eggs are produced and whether they'll produce a chromosome abnormality in the embryo and potentially the baby. That's sort of very low percentage for the individual. But as you start drifting into the infertility world, that percentage goes up sort of dramatically higher. I don't mean dramatically like 50%, but, it becomes 5 to 10 times higher than the normal population, So it's, again, worth doing. In some countries, that's a standard part of the workup for working up an infertile couple. Okay, they don't need to have any other information. They just say, you're in the infertility world, we're going to do this test. So that's a relatively inexpensive test as well. So that could be worth doing. As soon as you start having miscarriages and other problems, that incidence of that issue becomes even higher. And that's why it's included in a miscarriage workup, for example. Or if you've got, if the man has very abnormal sperm parameters, that's another reason to do it. So it's one of those things where you can wait until you've got a problem, or you could say, actually, I want a clean bill of health to begin with. And it's usually used as a sort of rule out test. If you don't have, if you don't see anything in either the male or the female, okay, that's great. It doesn't mean you're going to conceive instantly. It just means that's one less thing to worry about. So that definitely would have an impact on, if you ended up doing PGT-A, that would have an impact on whether your chance of having abnormal embryos is higher or lower. But you could do neither of those two tests and just do PGT-A if you wanted, and then you're back to the age-related aneuploidy risk. Okay, so I know there's quite a lot to sift through there, but again, it all depends on your sort of attitude to risk, your budget, and what you think is sensible to do before trying to conceive.
Okay. Thank you so much indeed. And now we will go for our final question. This is actually a follow-up from our previous patient. Let me just show you here. So this is the patient who is 33, right? And so the question is, are there any further tests like immunology testing, PRP, to improve success of aneuploid transfer? So
that's not really my area of expertise, but I would say for number one, I'm not aware of any, unless you have a particular risk factor for the immunology testing, I wouldn't say there was any specific reason to start doing that, because that definitely, I know there are clinics that do it, that particular one, but I don't believe the evidence is really strong for doing that. PRP I thought was more for egg quality, but I might be wrong about that. And then any special embryo transfer protocol, I think probably that's to have a conversation with your doctor about whether, I think the two real protocols we should be talking about there are either a natural cycle, which some doctors are saying they're getting much better results in than a medicated cycle. So you have a lot more control in the medicated cycle. And that means if you were using a test like endometrial receptivity, for example, that would work better in a medicated cycle. But a lot of doctors are now saying they're getting better results with natural cycles. So have a conversation with them about those two types of cycles, and again, what their success rates are in their clinic right now using those two types of cycles. And they almost certainly will be using both types. But I don't think it's but I don't think it's specific to your embryo, whether it's been tested or not. I think that's more about, I don't want to say how precious, because every embryo is precious, but how much you've invested already, and whether you want to do more tests or make different decisions based on the fact you've done all that and you don't think you're going to get another euploid embryo in the future.
Okay, thank you so much. I mentioned this is our final one, but Karen has added two short ones. I think we can still answer them. What do you look for when researching a basic chromosome test? Does it have a specific name for the test? And should a female and male do this test, or just male first, if you can clarify those?
Okay, so that basic chromosome test, I think what we're talking about is called a karyotype, begins with a K, Karyotype. It's a very basic test. It's been done for decades. It sort of hasn't been supplanted. Actually, it still exists in its original form. And I would say that's it. And I would say unless you have a specific, let's use an example where the male has got severely abnormal sperm parameters, then it's like, yeah, do it on the man, because you've got a reasonable chance of finding something. But in reality, as with all medicine, unless you're absolutely sure that you're going to get a negative test on one or other of the couple, you're almost better off doing both at the same time. Because what if you do the man, he has an abnormality and she does too, and you haven't seen it? You're going to get some really funky results later on. Or you test the man, he's negative, and then you go, well, I suppose I could test the woman now. But I think the way that human bias works is you think, oh, he's normal and he was the one we were worried about, so I probably don't need to be tested. So I think if you can afford it, it's sensible to just both do it, in terms of that rule out type scenario where you say, well, look, I just want to be clear that that's not a problem that we're going to have in the future. And it's a relatively inexpensive test. And as I said, in some countries it's routine. In some places it's part of a panel of tests. So, a sort of basic infertility workup. So let me put this in a different way. If all these tests were free or extremely low cost, I can't imagine many doctors not using them, honestly. Carrier screening and karyotype for sure. So that should tell you something, that they're sensible tests. The results are very clear in a way that sometimes PGT-A results aren't. And if you get an abnormal / positive result, it has implications, and there are things you can do about it. So I think it's a very useful test in that respect.
And brilliant. Thank you so much for answering those two extra questions. There are some other ones, but more related to other things. I'll be happy to forward them to Alan, so he can definitely get in touch. And of course, you can always get in touch with us if you have more questions. But we are going to be back as well with some other topics. We will be back on next week, actually, on Tuesday, so you can join us, and if you have more questions, we'll be happy to help you out. Alan, thank you so much for joining us today. Let me just add that Alan Thornhill, he is the founder of the Fertility Guy. You can follow him on his Instagram account, and I'm sure you will find it useful as well. Alan, as always, a pleasure. We will have you here, I know, quite soon. And also I want to add that on the 30th of July, we will also have a webinar with Alan, who is actually hosting this event with 3 other doctors, Ask Your Doctor event. You can find it already on our website, so I can only encourage you to sign up for it. We will talk about the low ovarian reserve. So I can only simply encourage you to simply join us and ask your questions, of course. Thank you. Have a lovely evening, everyone. Alan, anything else before we finish?
No, thanks very much. And you've got so many ways to contact different people. You can always contact me directly as well. So you've got all of those options. Okay.
Definitely. Thank you so much. Take care, everyone.
Bye-bye.
And have a lovely evening. Bye.
Bye.